So this is a talk on something after all the high tech, and we are going to something very basic, just small incision cataract surgery, a step-by-step guide. So I'll just have changed it a little bit. I'll just explain to you what I'm doing. So basically, you need to have some kind of an approach to when you learn. What are all the things you need to know about any surgery? So I just thought to make it a little different, I'll put it this way. So every step has got some checkpoints. What do you need to know? You need to know first, what is the goal? What's the target you want to achieve? Then what tools you have at your disposal? What are the tips? What are the helpful points that you can use to achieve the goal? And what are the traps? What are the things that you can do that will get you into trouble? That will make the subsequent steps difficult. And what we call the tell. The tell is in gambling. In poker, they look at the opponent and they kind of guess what's happening. So you look for a tell. So you have some kind of a crystal ball, or is the eye telling you something? What is going to happen next? Not next minute, but next second. That 1 second of advanced warning can really help you sometimes to avoid a complication. So let us see how it applies to a very basic step, say superior rectus. Now that's a very basic step. What's the purpose of the step? The goal is to rotate the globe downwards, get good exposure, good fixation, and then during the nucleus extraction, you want a good counter traction. That is your purpose. That's the target. What tools do you have? You've got the superior rectus forceps, which is a kind of a stout forceps. It has got a bend which is about 10 millimeters from the tip, and the superior rectus tendon is 7.7 millimeters from the limbus. So when the forceps bend is at the limbus, the tip will reach just beyond the tendon. It will reach the tendon itself, and you'll be able to lift up the tendon for the passing the sutures. Then what is the tip you have to use? You should know where 12 o'clock is. Once the eye is blocked, 12 o'clock may rotate. So you know 12 o'clock by looking at the ciliary vessels. The ciliary vessels will guide you to where is the 12 o'clock position. And you slide the forceps from the limbus posteriorly and keep the jaws wide as you go back, because you want a lot of tendon in the forceps. When you reach the required point, when the bend is at the limbus, then you pivot. You make the tip press on the globe, then close, and that will lift up the tendon. And the tendon is visible as a glistening structure. So it's not that you just blindly hold, you can see the tendon. So you want to look at that. So that video is showing this. So you start at the limbus, slide back. So I have a little bit overshot, but anyhow, I'm trying to press against the globe. Now we have the tendon there. It's a glistening structure, clearly visible, better visible under the microscope. Apologize after the great quality of the videos. This is the best quality which I have in my microscope. And then you want to pass the needle, making sure that it is parallel horizontal, and not the tip should not go into the sclera. It should be horizontal and up immediately. Once you cross the limbus, up immediately, avoid the vessels there. And then you can hold the needle tip, and you have to supinate your hand, take out the needle. So what is the trap there? The trap is you can have a globe perforation. So always pass under direct vision. Don't just pass. Always see the tendon, see the needle passing, and pass under direct vision. Lift the tendon up to create a space. Pass needle horizontally. That is correct. And do not pass needle pointing downwards, because that is going to perforate the globe. And a round-bodied needle is always better. As a PG, you may not have a choice, but if you have a choice, choose a round-bodied needle. And to avoid hematomas, avoid the blood vessels. So this is the traps to avoid. So what's the tell? How do you know where you've got it correctly? The tendon should be seen clearly. The globe will rotate down when you pull the suture, and you'll have a good exposure, good fixation. So you know you've done the right thing. And perforation should not ever happen, but if it happens, how you'll know is when the eye feels soft and when you lose the lead globe because of the vitreous hemorrhage. So this is a kind of an example, a simple step, which you can break it down and you can look at what you need to do. So now if I do the whole surgery this way, it is going to be pretty a long talk, I think. So what we'll do is let us look at what is the most important. So you got the lens. The lens is inside two containers. The inner bottle is your capsule, and the opening you're going to make is the rhexis. The outer bottle is your wound, and the opening you're going to make is outer bottle is your eyeball. The opening you're going to make is the wound. So you got two bottlenecks, and they're not just bottlenecks, they are the rate limiting steps. If something goes wrong here, everything else is going to have a cascading problem. So you need to get this absolutely right. So we'll just concentrate on these rate limiting steps. So there's a triplanar tunnel which you want to achieve, that's your target. And it has to be a safe tunnel. Small SICS doesn't mean small incision cataract surgery, it means safe incision cataract surgery. It has to be a safe tunnel, should be stable as far as possible. If If you have the slightest doubt, please suture. So there is nothing wrong in suturing. You don't become a smaller surgeon by suturing. You should suture if you have any doubt. You can try for a reasonable astigmatism, which is possible with SICS. And a smaller incision is less safe, though the SIA will be less. So there is one more concept called as the Cox incisional funnel, which means that the SIA depends on two factors: how close the incision is to the globe and how long the incision is. So it is said that it is directly proportionate to the cube of the length of the incision and inversely proportionate to the distance. Meaning if you go back, you can make the incision much longer. If you go forward, you need to make the incision smaller. And so the upper line shows 3 equivalent incisions. They're all astigmatically equal, wherein there's a straight incision, a Frohn incision, and 2 straight incisions. They all fall within the funnel, so they are equal. The lower incision is a straight and the Frohn, which is beyond the funnel, so this will cause more astigmatism. Then you have to think about why the Frohn incision is such a good incision. So it is something like if you have a hanging chain, if that's a very stable structure, which is the shape taken by a chain, it's called as a catenary curve. So like a suspension bridge. So basically when you create a Frohn incision, you're creating a very stable kind of a geometry, which makes the wound very stable. So that's why you aim for a Frohn. But as a beginner, if you do a Frohn, you're going to have a lot of problems because you'll start posteriorly and you will not actually reach close to the limbus. You'll find the whole wound is posterior. Then you have a very long distance to manipulate and subsequent steps become difficult. So better option is to use what is called as a Blumenthal or the batwing incision. So the corneal wound is, you initially make the straight incision close to the limbus, as close as you want, and then the 2 oblique cuts. So then you're able to control the distance of the incision. And to note that the inner wound has to be wider than the external wound. Why it has to be wider? Because the cornea is a non-stretchable tissue, whereas the sclera is a stretchable tissue. If the nucleus is brunescent, you make side pockets. Otherwise, you don't need to make side pockets because there's extra bulk in a brunescent nucleus. I think I've done something. Okay, fine. So then we come to the instrument. So now we talked, what are the tools you have? The tools you have are the crescent and the keratome and the 15 blade, if you use that. So you need 3 tools for the 3 planes of your incision. And the concept of bevel has to be understood. So the crescent is a bevel up incision. Imagine a dolphin. A dolphin's body is designed to dive. So because it's got a smooth upper surface, imagine the lower surface as a cutting edge, it's going to dive down. So your bevel up crescent is going to stay down as you tunnel. So the main risk of a crescent dissection is you'll have a buttonhole. The bevel up avoids your buttonhole. When you come to the keratome, there are 2 options. You have got bevel up and bevel down. If you have a bevel down keratome, it's something like a sailboat. It will sail forward. It will lift up. So if ideally in SICS you'll have to use a bevel down keratome, but it may not be available. So if it's not available, what you need to do is you need to dissect more into the cornea and then enter with the bevel up keratome so that you have an adequate corneal valve. So once you made the groove with the blade, then you make the tunnel. So I'll just show you something that I'm doing here. This is a batwing incision or a Blumenthal. We are converting the vertical groove into a horizontal groove by undermining. Now just watch here. What I'm doing is I'm trying to adapt the blade to the surface of the globe a few times so that my muscle understands how the curvature of the globe is. When you look at the globe through the microscope, you cannot understand how curved the globe is. That's a common mistake done. The pages will dissect horizontally. The globe is not a horizontal structure. So once you do it a few times on the globe, you're kind of self-simulating and teaching your muscle how to dissect. Then when you go back, just let your muscle do the same movement again, and you will be in the right plane. With the crescent, you need to dissect more posteriorly. Most of the cutting is the backward cutting rather than the forward cutting. So I'll move on to the next slide. So I'm showing the same thing from the side so that to explain what I just said. So once we have undermined the edge to get a uniform edge, now put your crescent on the surface, not in the tunnel, on the surface of the globe, and see which movement of your fingers is going to adapt the crescent perfectly to the surface of the globe whenever you move the crescent all around. And just now your muscle is trained, just like Tendulkar practicing his shot. Now his muscle is basically, he doesn't need to do it, but he still does it because he wants to get his muscles tuned up. Now when you go in, you feel your muscle. More than what you see in the wound, you feel your muscle and it imitates the same movement and you are in the correct plane when you do the whole dissection. Just see how curved the globe is, how much it has to tilt to dissect the plane correctly. This is very difficult to teach with any number of words to a PG, but if they can do this exercise, they will be teaching themselves when they'll be learning this. I'm sorry, 1 second. Okay, so next thing is that about the entry with the keratome. So if it's a bevel down keratome, definitely you need to dimple down. Not so essential if it's a bevel up. So initially you're dimpling down to get the entry into the anterior chamber. Once inside, let your hand relax and go back to the same position like it was in the crescent and dissect it in more or less the same hand movements as you used for the crescent. The tip should always remain in the anterior chamber because if it comes back into the wound and goes back again into the anterior chamber, you're likely to strip the descemet membrane. So the same thing is being shown from the side. So you go sideways so that you don't prematurely penetrate the floor of the incision. Now you align your blade straight. You dimple down, enter the anterior chamber. Once you're in the anterior chamber, you see the cut margin of the descemet membrane, and then relax your hand, go back to the position it was in earlier, and then cut only when you're advancing the blade so that you get a clean cut. It's not a zigzag cut. So what are the things that can go wrong? The traps you can get into are the buttonhole and the premature entry. The buttonhole is when the blade rides up. The premature entry is when the blade goes down. So what will tell you that you're going to get a buttonhole? You'll get a buttonhole when your sclera is very thin. So the blade is more visible than normal. Normally when you look at the blade in the tunnel, the outline will be not visible, but the blade will be visible. If you can see the outline clearly, you're too superficial, you're going to buttonhole. The tissue will drag as you dissect. So as you dissect, you'll find the tissue is moving over the blade. And you'll see a small blot hemorrhage just before you're through the episclera. You'll see a small bleed there. If you stop there, you can actually maybe tunnel deeper and save the situation. So you look for that small episcleral bleed, which tells you that you're going to buttonhole the eye. The premature entry usually happens when your sclera is thicker above the blade. So means you've dissected too deep, and you cannot see the blade clearly. So you're too deep. And typically what will happen is that when you're dissecting, you'll think the sister has given you a very good blade, or suddenly you're operating very well because the dissection will be very easy as you go deeper into the tunnel. So when you see that the dissection is unusually easy than what you're used to, the resistance is less, you're going to have a premature entry. And when you have a premature entry, usually you'll also have a bleed into the anterior chamber. And so you know that you had a premature entry. So when you're, now I'll just skip because now we're talking about the wound. The wound has got two things. One, you made the wound. The purpose of the wound is to take out the nucleus. So instead of, we'll just jump to the nucleus extraction because we're talking about wound still. So when you talk about nucleus extraction, what do you want to do? Safely you want to take out the nucleus through an adequately large wound. And you want to protect the cornea with viscoelastic. You use your irrigating vectors properly and use the counter traction with the brittle force, the brittle suture. The tip is that you need to always depress the floor of the wound. Typically, what you would be tempted to do is you would want to hold the nucleus in the vectors and you would want to pull out or pull up. That will cause the viscoelastic to get displaced and you will lose endothelial cells. Therefore, you have to press counterintuitively, you have to press the vectors down as you extract the nucleus. The trap is that if you start injecting saline early, iris will come out of the wound. It will be underneath your vectors, you will not see it. And as you extract, you're going to cause a large superior iridodialysis. Therefore, always depress the wound, let the nucleus settle on the vectors, only then inject saline and then extract. So the left side is showing you, and the right side is the same thing from outside. So the vectors is going inside. The nucleus is in the anterior chamber already here. So we are inside. We're not injecting saline now. We are depressing the wound. Now the nucleus is on the vectors, and now we inject saline and continue to depress the wound as you extract. So in this particular patient, it's a thick nucleus and is stuck in the tunnel. And I'm going to use a SICS key and bring it out. But if the bulk of the nucleus does not come out, then be careful. You need to enlarge the wound. Here, most of the nucleus is out, so I can just put viscoelastic and I can rotate the nucleus out. But if most of the nucleus does not come out, if the equator of the nucleus is still inside, the wound is too small. So that is out now. Fine. So suppose your nucleus extraction is a problem. Now, how will you know if obviously if nucleus extraction is a problem, then you need to decide whether you'll try again or you will have to convert, okay? So if you're finding difficulty, first check the internal wound. The commonest thing is that the internal wound is not large enough. That is the most common mistake. If that is large enough, then you have to dissect the side pockets of the crescent and enlarge the external wound also. And you make one more attempt. If 2 attempts don't work, it is better to think of converting. And the way to convert is to make it into some kind of a extra capsular trap. Means you make both the cuts vertically from the flap, reach the limbus, use corneal scissors to cut. Then you can suture the sides like an extra cap wound. You can suture the flap like a trap wound. It becomes simple. If you cut obliquely, then it becomes difficult because you'll have to do a lot of sutures to just get the same effect. So you need to think which would be the most easier way to suture. So when you do the rexus, you want a large enough rexus and to take out the nucleus. And it doesn't matter which way you do. You can do a can opener or you can do a rexus. And generally speaking, you can use the rexus needles, forceps or the microforceps. And for beginners, it's better to do the can opener because the commonest mistakes beginners make is make a rexus small. Beginners don't know how to make a large rexus and keep it controlled. So they can make a can opener capsulotomy, but you cannot hydrodissect forcefully. You can do a gentle hydrodissection. It has to be mechanical prolapse. Always keep the anterior capsule flat. And if it's a short eye or intumescent cataract, you need to use mannitol to help you keep the capsule flat. And use lots of viscoelastic when you do your rexus. So when you do a rexus, you can divide the task into 4 steps. First is to start with a radial cut from the center. So once you made a radial cut from the center, you pull on the edge of that cut and convert that into a curvilinear flap. Then you fold the flap over. So once you folded the flap over, then you start moving the flap. So you'll see surgeons doing a beautiful fast rexus. Don't try to imitate that. Break it up into the simplest possible steps. Make a cut, pull the edge, make a curved flap, fold the flap, and then move the flap. And in SICS, the rexus has to be large, preferably larger than the optic size. So what are the problems you can have? One is you can have a small rexus. The other is an extension. An extension is, imagine you're skiing down a slope and you want to ski around a mountain, but you're skiing down the slope. So chances are you're going to not be able to maintain a circular pattern. But if you're on a flat surface, you can comfortably ski in a circle. So basically, when the capsule is bulging forward, you're not going to be able to control the rexus. It is going to go peripherally. And as you operate, visco is escaping. So the capsule is bulging forward. The vitreous is pushing from behind. When the vitreous pushes from behind, the zonules are becoming taut. It is pulling the rexus peripherally. So you need to keep the capsule flat. Flat capsule means relaxed zonules. Relaxed zonules means a controlled rexus. So here we look at what happens. This is an intumescent cataract. So I've gone through the side port. This is a SICS case only. I'm making a kind of a curved flap so that the fluid escapes, not suddenly. And it's a controlled escape of fluid. Then you can go in with the empty syringe. Empty syringe means no air in the syringe. Empty syringe. Vacuum. So go inside with an empty syringe and you suck out some cortex from the bag. What happens now is you can see the capsule is becoming concave. The convex capsule is now becoming concave capsule. Once it becomes concave or flat, you are in control. You can even go through the main wound now because now it's decompressed and aspirate some more cortex and make the capsule flat or concave. Once you do that, then you can make the rexus with the forceps because now there's a soft cataract, there's no resistance from the nucleus, so you will have to use forceps because the needle will have nothing to press against. I think we'll just, can we just jump a little bit forward? Just jump a little bit forward, please. Okay, fine. It's okay, I think it may take a little bit time. So the Rex is being done. Now what is happening here is, now it has escaped over there. So I'm going to change the uterata forceps. So first visco, flatten the capsule. Sorry, there's a bit of editing which should have happened over here. So I'm aspirating some more cortex, making the capsule more flat. Can you move the video a little bit further? Is it possible? Let's go to the next one. Okay, it's all right. Anyway, that was a double Rexis. It's fine. We can skip and go to the next slide. Okay. So how do you know that the Rexis is going to extend? See, when you make a dual Rexis, if you folded the flap carefully, you will see that there's a right angle where the capsule is folded and the cut margin is there. If you start seeing an acute angle, that means the angle is pointing outwards, the Rexis is going to extend. Once you're trying to do the Rexis, if the flap does not move, it has already reached the zonules. Once the flap does not move, you should not pull the flap because you already reached the zonules. Any more pull is going to make the tear wrap around the nucleus. So stop if the flap is getting stuck. Don't force the flap. When you're more experienced, you can do what is called as a Little's Rexis rescue, which is something you can read about, but you need a little bit of experience before you can do that. So generally speaking, if the Rexis extends, stop there and try to make a relaxing cut. So once you've done the Rexis, you can do the nucleus prolapse. So one way is what we are used to, which is the hydrodissection, where you try to hydroprolapse, where you try to retract the capsule on one side and inject the fluid, allowing the fluid to come out of the bag. Once you've injected fluid and the nucleus is out, please don't take out the cannula immediately. Let the trapped fluid escape. Then put visco, and you have to look at, there are two corners, one in the nucleus, one pole which is out. So you have to support the corner which is nearest to you, lift it up, and move that corner towards the prolapsed pole side, where the pole is prolapsed. So in this case, I have to rotate left. Rotating right will not work. It has to go left ways. If the nucleus had come out the other way, then I would go the other way. So you go from the corner, lift up the corner, and move it towards the prolapsed side. So lift up that corner and push it towards the side that's already prolapsed. So you do it more times if it doesn't happen, one or two goes, and then you got the nucleus out. The left side, what we are doing is this bimanual method where you're retracting the capsule with the second instrument, pushing the nucleus centrally so that the nucleus margin is seen. Let that nucleus margin settle on your second instrument so it supports, and then rotate the nucleus over the second instrument. This is very helpful when you got a hypermature cataract where there's not much support. So IOL implantation is the next thing which I thought I'll just tell you about. So I wanted to talk about two things. One is the wound, the other is the capsule management. Making the wound, taking out the nucleus from the wound, making a Rexis, and prolapsing the nucleus. There are two critical things where most of the time we get stuck. One thing which commonly happens is that we're not able to put the lens in the bag. After a beautiful surgery has been done, then the lens is partly in sulcus, decentered. So how do you do that? So basically there are three initial steps. You slide the leading haptic on the PC so that it gets under the anterior capsule, and put the trailing haptic into the anterior chamber so it stays in place. Put visco, deepen the chamber, and then you do three more steps. What are the three more steps? So now So the lens is going into the anterior chamber. Haptic is touching the posterior capsule, and then you slide in touching the posterior capsule so that the anterior capsule is now over that haptic. The second haptic is going to be put into the anterior chamber angle now. Leave it there. Put visco, deepen the chamber. Now look at where the dialing holes are. The dialing hole now is at the left side position, which would be in your case the 9 o'clock position. You need to bring it a little bit lower to around the 7 o'clock position. So why you want to do that is now you can grasp the dialing hole and pull it towards the other dialing hole. This will compress the haptic that is in the bag. The haptic in the bag needs to be compressed so that the diameter of the lens becomes small enough to push it into the bag. So you need to pull it, then press it towards the optic now, towards the posterior pole of the lens and go. So there are 3 things you need to do. Pull, push and dial. If you just dial, it's not going to go into the bag. Okay. So I think that is what I want to say in this particular topic. So you can look at every step, every single step. There are points to be thought about in which we can learn. And I think to mimic what ma'am said, what Sheetal ma'am said. So like basically athletes train, and we are basically creative athletes. Surgeons are basically creative athletes. We are not geniuses. And so you need to train if you want to get better. Thank you.